Good afternoon slash morning, everyone. Some people consider 11 o'clock morning, some afternoon. So I will say both. Thank you so much for joining our webinar today. I'll just wait a couple moments while everyone's filtering in. Excited to see everybody. Thanks for coming, Erica, Heather, got lots of Jennifers, Mary, Lisa, Samantha. Wow, lots of people coming in. Thanks so much for coming today to learn about open enrollment and compliance, best practice for employers. We're hoping to give you a lot of really great resources and tools today for your organization. So I'm going to just give a very brief rundown of how the webinar works, and then we will turn it over to Sarah. So just so that everyone knows, this webinar is recorded, which means that at the end of the webinar, everyone who registers will be able to review the recording, share it with people, and also you will get a copy of the presentation slides as well. This also is interactive, which means that you can ask a question for Sarah at any time, and we are going to reserve answering those questions for the end. And then just so you know, you don't have to stay for the whole thing. So if for any reason you have to jump out, again, this is recorded, so you can always access where you left off later in the day, later in the week, later in the month, whenever you'd like to look into it. So I'd love to introduce our speaker now, Sarah Borders. Sarah is an industry leader in providing guidance on legislative and regulatory topics such as ERISA, ACA, Section 125, COBRA, HIPAA, Medicare, secondary payer, and tax advantage accounts. In her previous roles as a vice president of benefits compliance with NFP and a director of compliance with a regional benefits firm, she's served hundreds of employers' needs, and from identification to resolution, written dozens of articles on regulations, and frequently presents on compliance topics. She is an active board member on the Austin Association of Health Underwriters and a member of the NAHU Legislative Council Employer Working Group. Her designations include an active license with the Texas Department of Insurance, CEBS, Certified Healthcare Reform Professional, NAHU HIPAA and ACA certification, and Healthcare Service Associate with an AHIP. That's a lot of acronyms, which means that's a lot of hours that Sarah has dedicated to learning about compliance. So she is definitely a subject matter expert, and we are very thankful for her partnership. Thank you so much, Sarah, for being here.
Thank you, Cassie. It's great to be with you all today. I have a little bit of a screen share issue here, but I'm going to stop sharing and start again here. My apologies for the little technical issues. One more time. I'm sorry, folks. We get on here early and then it doesn't work right still. Here we go, I think. Okay. There we are. Thank you for your patience. So I'm Sarah Borders, and I've worked with many of you already to sort of mostly look at your health plans with checkups. In other words, our gap analysis. So I'm really excited to be with you all today to go through some of the new requirements that are coming as a result of this piece of legislation called the CAA, and some very similar types of rules called the transparency and coverage rules. These have really gifted us with a lot of new requirements for health and welfare plans to comply with. So we're going to go through some of those new requirements, things that you need to know, especially if you're sponsoring a self-funded group health plan. Then we'll look at some additional 2023 updates and how that will impact your 2024 renewals. And I'd love to go through a checklist of sorts of open enrollment planning to-dos that have been around for many years, but typically can get missed. And when they are missed, some big problems can arise. So we want to be as proactive as possible, help you understand what it is that you need to do, and set you up for success, especially if your plan renews January 1 or December 1st, one of these kind of end of year plan year changes. So first of all, under the CAA, we have several different requirements, and I'll go through those with you in just a moment. But the biggest one that is upcoming is what we would call the gag clause prohibition compliance attestation. And that's quite a lot of words here, but really what this entails is kind of two-part requirement. First of all, under the CAA, health plans are not allowed any longer to enter into any contracts with TPAs or networks, and typically TPAs contract with networks of providers. In those contracts or those service agreements, there can't be anything that's construed as a gag clause. And I'll show you in just a moment what a gag clause actually is, but essentially it is a contract term that would prevent the plan from getting provider-specific cost data or quality of care data. And so that has been around since the passage of the CAA, which was passed at the end of 2020. And so now the secondary requirement to that requirement not to have these gag clauses is for the plan to affirmatively attest to the fact that their contracts contain no gag clauses. And you have to do it by submitting an attestation directly to CMS on their specific website portal. So these attestations are required for every single group health plan out there. That includes small group plans, large group plans, fully insured, self-insured, grandfathered plans, and non-ERISA plans. So if you have a church or governmental plan, it includes you as well. So this attestation piece, the part where you have to actually tell CMS or attest to CMS, to the government, that your plan contains none of these gag clauses, it has to be submitted before December 31st, 2023. So this coming New Year's Eve, and then each year thereafter by December 31st. So every New Year's Eve, hopefully this is not what you're doing on New Year's Eve and you're done well before the holiday season, but that is when the last possible date is to submit it through what we are calling the GCPCA website or portal. And again, that stands for Gag Clause Prohibition Compliance Attestation. GCPCA is a lot easier to say and a lot easier to spell. So if you are fully insured, whether you're, again, small or large, whether you're 30 employees or 500 employees, fully insured plans can shift the liability to your insurance company. So if you're with, for example, Quartz, Dean, United Healthcare, Aetna, Cigna, Blue Cross Blue Shield, Anthem, any of those types of carriers, then generally speaking, what we have seen is that the carriers are going to be submitting these attestations on behalf of their entire books of business. That's not totally set in stone, but from the trends that we're seeing, we're starting to finally see responses from the carriers, and they are saying that they will submit these attestations on behalf of their fully insured plans, their book of business that is fully insured. However, if you are self-insured or even possibly level funded, which is really just some sort of way to kind of get around the ACA rules with a fully insured plan, a level funded plan is considered a self-funded plan. And so with self-funded plans and with level funded plans, the employer again can enter into a written agreement with your TPA, but the legal requirement remains with the plan sponsor, the employer plan sponsor in that instance. Unlike fully insured plans and fully insured carriers, we have started to see responses from the TPAs and the self-funded vendors that they will not be submitting the attestations to CMS via this GCPCA website on behalf of those plans because they're self-funded and because they don't feel like they have the authority to attest to the fact that their contracts contain no gag clauses. In fact, the employer is really required and expected to submit the attestations themselves, again, if self-insured. So for example, if you're with, I believe UMR is one example that has already told us, maybe United Healthcare, UMR, they've already told us that they will not be submitting the attestations on behalf of any of their employer plan sponsors that they work with. That will mean that you will need to go onto this website, the last bullet there, and attest to the fact that your plan contains no gag clauses. Now, what the TPAs are typically doing is giving you a statement, or like a letter or some kind of statement that says that their contracts with these networks, because typically medical claims third-party administrators contract with different networks of providers, so doctors' offices, clinics, hospitals, all of the providers that would be in a network, they contract directly with them, or they have sometimes even their own networks that they set up, direct contracting, and they have reviewed their contracts and can say with confidence that the plan that you have entered into or the contract that you've entered into with them contains no gag clauses. So I want to make sure that everybody understands this quite early. We are still in September. And again, this is the first year that this is going to be required. And we didn't know exactly when this was going to be required until several months ago. And even at that point, we didn't know what it was going to look like. So this is an early reminder that you will need to take action on this, especially again, if you're self-insured or possibly even level funded plans. So this applies to medical group insurance. It does not apply to accepted benefits such as standalone dental or vision, FSAs like health FSAs, ICRAs, or health reimbursement arrangements. What happens if you don't do it? Well, I guess fortunately or unfortunately, the rules do not talk about a specific penalty for failure to attest to the fact that your plan contains no gag clauses. All it says is may be subject to enforcement action. So possibly that means some sort of corrective action plan if you were audited or investigated by the Department of Labor, or perhaps some kind of complaint was made. They may ask you to correct it, or they could take action and bring suit, through the courts. But it seems like in most cases that is an extreme example, and they aren't really always in the business of just doling out penalties. So that is somewhat different than how the IRS tends to work. So the main enforcement body here is going to be the Department of Labor and CMS. But overall, what you need to know again is that if you're fully insured, you want to make sure your carrier is doing it on your behalf. And if you're self-insured, you want to take steps now to plan on attesting via this website that I've linked at the bottom. I will tell you now that this attestation is not difficult. It is a couple of screens. You have to click some boxes. You have to fill out some information. This is nothing like if you were involved last year with RxDC or the prescription drug and healthcare spending submissions. This is nothing like that. This does not require a soft credit check. This does not require multiple registrants. This does not require 8 different data pages to be uploaded. It's just a simple attestation. But again, you'll want to confirm if you need to attest or if somebody else is doing it on your behalf. And I'll say right now that your insurance advisor, whether Housman Group or anybody else on your team, should not at any point submit on your behalf, because they cannot legally bind you to this attestation. And so the employer should be the ones to attest themselves. But we're trying to help you as much as possible to let you know what you need to do in time. Yes, you can have a copy of the slides. If you do have any questions, like Cassie said, please type them into the Q&A box, and I'll make sure to try to answer them as we go. Okay, so in addition to the gag clause compliance attestation that I just mentioned, that is kind of the most, the one that we are looking at coming up the quickest. There's other different areas of compliance that have applied or started to apply under these transparency rules and the CAA. So if you'll remember last year, 2 times last year, actually, the RxDC reports were due to CMS. Again, this is different than the gag clause attestation, but you'll see the first bullet is labeled RxDC reporting for 2023. So if you'll recall last year, again, this report called RxDC is required to be uploaded to CMS each year, no later than June 1st. So for the next round coming up. This will be round 3 coming up. You'll want to ensure that you're answering any surveys that your carrier or TPA send to you, and those would probably come around February or March, so that they can submit this information to CMS in a timely manner by June 1st. Last year, what we saw a lot of was if there was no response for the employer, then in some cases, they said we cannot submit the RxDC reporting on your behalf, and therefore you are required to do it. I will say, do not put yourself in a situation where you're the one having to submit the RxDC report. It is very complicated, very complex. It does require soft credit check. It does require multiple registrants to be able to coordinate this data. So there needs to be action taken. More to come on that because we're a little bit far out from it again when it comes around again. But just know that Hausman Group is monitoring our carriers, service providers, vendors about what they are doing and then any actions that you need to take. But I did want to mention it because it does need to stay top of mind because it's due every single year by June 1st. Next, we have the price comparison tools. Or let me go back to the RxDC. Are all companies required to do the RxDC report? Yes, very good question. So fully insured plans, self-insured plans, all required to do the RxDC report. This is not the first time we are doing this. This is the 3rd time now that we're dealing with this. Fully insured plans will have, most likely the carrier will do it on their behalf, but self-insured plans may have gaps in the data from prior years, or maybe you renew in the middle of the plan year. And so there can be some information that needs to be filled in. In some cases, the TPAs are not submitting on behalf of the client. The client is given the information from the TPA, and then they are required to go and to submit it themselves. So it just depends on your TPA, again, your medical claims payer, and where their stance on RxDC is, especially for coming up the 2023 plan year, the one that we're in now, that's due by June 1st, 2024. How does Hausman Group do it for us? No, you're responsible to do this on your own, but we do provide assistance. This again is an employer responsibility, and your health insurance broker cannot do it on your behalf, unfortunately. So these are legally binding submissions that would be very similar to someone reporting to the IRS on your behalf. This is really the same type of thing where the employer has to submit it themselves. So if you have any questions, reach out to your account manager and make sure that you understand what it is you're going to need to be prepared for RxDC coming up again in several months, but it's good to keep talking about it. So next we have the price comparison tool. So a portion of this searchable internet-based self-service tool was to be available to employees by the time your plan renewed on or after January 1st, 2023. All of the services are required to be disclosed and available and upon request for plan years beginning on or after January 1st, 2024. So here is something that most carriers and most TPAs are on top of, they have in place. And so there may not be more here for many of these items for you to do rather than just make sure that your carrier TPA actually has these in place. And again, we're monitoring this. So we're trying to stay on top of this for clients as well. The air ambulance cost data submission, this has been delayed pending further rulemaking. And if final rules were to be issued this year, which could be, may not sure yet, that means that this air ambulance cost data wouldn't be due until March 31st, 2025. And again, for the second round, March 31st, 2026. So you can see here that the CAA gave us a lot of different submissions to CMS that is supposed to provide this data so that they can examine the cost of care, the cost of drugs, the cost of air ambulance, the costs of your employer contributions, and making sure that your plans contain no gag clauses that disallow you from being able to examine your costs, your data, your claims information. Couple of other things under the CAA and transparency rules would be the machine readable files. These were effective last July, and essentially what is going on with these is the carrier, the TPA, is pretty much required to post them to their public facing website. And so as long as they have it on their public facing website, then you're not required to really do anything more with it. It's not employer facing. It's not meant for, it's not employee facing. It's not meant for employees to be able to search these files. It's, as it says in the names, machine readable files. So it's supposed to be a way for developers and maybe even the government to extract data from your health plan carriers and TPAs, and to be able to cross compare cost analysis to try to make healthcare, health insurance, the cost of coverage more transparent, more competition, and to be able to provide actual costs of how much something, the price of something. Whether or not that's effective remains to be seen, but this is the requirement. And again, there's not really anything that you need to do with this specific requirement. The advanced DOBs, these are pending final rulemaking as well. So once we have more of a clear idea on how to comply with advanced DOBs, we will let you know. The No Surprises Act notice needs to be provided by the employer unless the TPA or carrier has it posted on their public website. And again, most do. So most of you would not have anything to give to employees because the carriers are complying with that requirement on their own public facing website. And as I mentioned before, the prohibition on gag clauses and related or the coordinating attestations required to CMS no later than December 31st, 2023. And then remember, each year thereafter. Couple of new limits announced for those of you that sponsor a high deductible health plan and have an HSA alongside your high deductible health plan. Most employers do have a high deductible health plan option with HSA, or are considering adding such an option for those who may want to be a little more cognizant about their healthcare spending by having just a larger deductible. They don't have co-pays. They have to pay for the cost of their care up till their larger deductible, and can have those funds available through an HSA, pre-tax funds that they can use for expenses that are not just covered automatically by a copay or some lower cost share. So they pay the full cost of the coverage instead of a copay or some sort of amount. And that's supposed to encourage consumerism. So if you do sponsor a high deductible health plan, then the out-of-pocket maximums adjust every single year, as well as the minimum deductible that's allowed. The HSA contributions also increase most likely each year. So this year, again, they've increased, as well as the accepted benefit HRAs. So going through this, if your plan renews in 2024, sometime in 2024, then the lowest that your deductible can be is $1,600 for self only and $3,200 for family. And the highest your out-of-pocket maximum can be for your high deductible health plan, again, is $8,050 or $16,100 for a family. If employees are allowed to contribute into an HSA because they are enrolled in high deductible health plan coverage, then they can contribute up to, for the tax year, regardless of when your plan renews, $4,150 for the full tax year, as long as they're enrolled each month into high deductible health plan coverage. Or if they are enrolled in employee spouse, employee child, or family, then they can contribute up to a maximum of $8,300, again, for the full tax year. If they're age 55 or older, they can contribute an extra $1,000. But again, they have to be enrolled in high deductible health plan coverage for the full tax year. So if they're enrolled only part of the year, then this is prorated. It's basically, you would take, for example, $4,150 divided by 12. That's your monthly maximum contribution. If you're only enrolled in high deductible health plan for a part of the year, which is very common when you have new hires come on. So you want to make sure that your processes reflect making sure and helping employees that make sure that they don't over contribute to their HSAs because they didn't quite understand how it worked. So again, if you're sponsoring or thinking about sponsoring a high deductible health plan, you'll want to be looking at these different parameters to make sure that your plan isn't exceeding or has too low of a deductible. And also the HSA contribution limit is in line with the 2024 tax year contribution limits. Okay, question came in. This prorating is for the HSA. Yes. So what I'm saying here again is if the employee is, for example, not enrolled into the high deductible health plan until March, let's say, because they're a new hire, or maybe your health plan doesn't start till March 1st, they would need to make sure and contribute the prorated amount because for January and February, they were probably not eligible to open and contribute to an HSA for those months because they weren't enrolled in high deductible health plan coverage. So you'll recall that you have to be enrolled in high deductible health medical plan coverage in order to enroll or to establish an HSA bank account and to put funds into it. So again, if they didn't enroll until March 1st, then they would need to take 4150 divided by 12, whatever that number is, and you would take out those first 2 months. So we would have 10 months of HSA contributions to put into their account. And that's the maximum, including any employer contribution. So if you match any HSA contributions or you put in a certain flat dollar amount at the beginning of the plan year, or maybe you add funds throughout the year, you'll want to make sure that together with their own contributions that they don't altogether exceed 4150, again, prorated for the number of months in which they're enrolled in high deductible health plan coverage. Another question, but if they had the HDHP all year and started the HSA a few months in, they can still give the max to the HSA right. So I think you're asking if they didn't open the HSA until later in the year, then they could catch up in that case, as long as they were enrolled in high deductible health plan coverage. The only thing is they're not allowed to, they're actually not allowed to pay for any claims that were incurred prior to the opening of the HSA. So there are a little bit of nuances here with HSAs, but overall they can still contribute the full amount even if they waited a little bit later to open their HSA, because again, an HSA is a bank account, it's their personal bank account. And so they can contribute the full amount if they were enrolled in high deductible health plan coverage. But any claims incurred prior to that, so maybe they went to the doctor under their high deductible health plan in February, and they didn't open their HSA until March, then they cannot pay for that claim retroactively because the HSA wasn't established yet. So those are just some interesting IRS rules. HSAs are lots of fun, but they do have some nuances to them that we need to watch out for. I'll come back to HSAs in just a moment when we get to the open enrollment checklist as well, because there's other things that I want you to think about when you're sponsoring a high deductible health plan and allowing employees to enroll or to take or open their own HSA bank account. Okay, so another thing that you'll need to put on your to-do list is to distribute your Medicare Part D notice of credible or non-credible coverage by October 15th. Why October 15th, you ask? That is when Medicare's annual enrollment starts. So the reason that group health plans have to distribute this Part D notice at this time is because CMS or HHS wants employees to have a way to determine whether or not their group health insurance that they might be wanting to enroll in or are currently enrolled in, whether the prescription drug benefit under your plan pays as good as or better than Medicare Part D. So this notice is supposed to tell them that. Credible means it pays as good as or better than Part D. Non-credible means it doesn't pay as good as Part D. The result of them enrolling or delaying Medicare based on or part enrollment into Part D, I should say, because they are enrolled in your group health plan and your plan was actually non-credible, they could incur a lifetime penalty if they delayed Part D enrollment and didn't enroll and your plan was non-credible. So there's no actual penalty or fine for you not providing this notice, but that could be something that happens to the employee if they're given incorrect information or given no information at all. So this applies to all group health plans. Again, no one is exempt from the Part D notice, whether you're self-insured, fully insured, small group, large group, grandfathered, non-ERISA plans. Everybody's in on the fun here. And for the most part, Houseman Group does assist with this credible coverage status and can assist with the Part D notice itself, but you as the employer plan sponsor will need to send it out to really all of your employees because it's hard to know who might be seeking to enroll in Medicare because there's other reasons you can take Medicare besides being age 65. Their spouse might be seeking to enroll in Medicare. So you really just want to distribute this Part D notice out to all employees, again, right before October 15th. And this is every single year. So check with your insurance carrier or TPA for credible coverage status. Again, Houseman Group is going to help you with this, and use the design-based method or actuary if your carrier really or your TPA will not provide. But again, I believe Houseman Group has the claims team to be able to make this determination on your behalf. So you really shouldn't be needing to hire an actuary yourselves. Okay. A bit of an update to the ACA affordability and the safe harbors to which it relates. So the affordability percentage, as you'll recall, back when the ACA was passed, was set at 9.5%. And each year it's gone up a little bit, it's gone down a little bit. It gets adjusted for cost of living and inflation. So last year it was 9.12%, and this year is 8.39%. So we have not seen it that low since the passage of the ACA. So what does this mean? It means that the employee's contribution, if you're kind of right on that line there, the employee's contribution is going to be less and your contribution may be more. And again, depends on how rich and generous your employer contributions are. But if you are really right on the line of affordability and we kind of get every single dollar out of every employee, then this percentage point is going to need to be taken into account. So as you remember, most of you who are applicable large employers, you know that you have to do your ACA reportings. In other words, your 1095-C forms, 1094-C that's submitted to the IRS each year. And on those forms, there are a bunch of codes. And on line 16 of the 1095-C, there are codes that we call the safe harbor codes that are codes 2F, 2G, and 2H. Depending on which one of these safe harbors on this slide, Form W-2, rate of pay, or federal poverty level that you're using indicates what code you put into line 16. The whole codes thing is a conversation for another day, but why I bring it up now is because, of course, we have a new affordability percentage to consider in our calculations, but also you need to figure out which safe harbor you are using or are going to be using for your ACA reporting. It's not something you should decide later. It's something that needs to be determined beforehand, before the plan year starts, so that you can ensure your coverage is affordable under the ACA. So box 1, W-2 income is used. So what these safe harbors are saying, just as a review, we've been talking about this for about 10 years now, is that the box 1 income, the amount that the employee is charged in employee contributions for the lowest cost plan, self-only coverage, the amount that is that they're charged cannot exceed 8.39% of the employee's box 1 income. The only problem with using the W-2 safe harbor is it's retrospective in application. So you would not know the employee's exact box 1 income until basically a year later. So it's really a little bit more risky to use the Form W-2 safe harbor unless you're very confident that you are going to know the box 1 income of these employees a full year before that number is actually published on their box 1. But it can yield the highest amount of employee contributions. So that's why a lot of employers use it. The middle one, rate of pay. This one is easy to use because it takes the employee's rate of pay. So for example, if they make $10 an hour or $15 an hour, you would multiply that in every instance by 130, or you would use their monthly salary if they are not hourly, they are salary. And again, their employee contribution cannot exceed 8.39% of that calculation, hourly rate times 130 for the month. So if you take your lowest paid employee, you can usually get at a number that will not cause you to exceed these affordability thresholds. The third one, federal poverty line or federal poverty level, is the easiest to use because it's not based on the employee's actual wages. It's only based on the federal poverty level amount that's in place for the 6 months prior to when your plan year starts. So right now, the federal poverty level is set at 14,580 for the 48 main 48 states. It's different for Hawaii and Alaska, but using that number is how you know how much you can charge employees per month. Again, for the lowest cost self-only plan, not for if you have buy-up options, not those coverages, but the lowest cost plan for employee-only coverage, not for their dependents. So using the federal poverty level is easy because you can tell right away that your employee contribution per month cannot exceed $101.94. Again, if you renew January 1st, February 1st, March 1st, 2024. So let me give you an example of how this would work. And I think this may be jogging a lot of your memories because a lot of you have dealt with this for many years, and maybe some of this is brand new to you. So for example, for the 2024 plan year, an employer will use the rate of pay safe harbor, again, this one in the middle, to set premium amounts for full-time employees. The lowest paid employee makes $10 an hour. To use the rate of pay safe harbor, the employer must use 130 hours per month. Again, this is regardless of how many hours they actually work. You just have to use 130 times $10 per hour, which gives you $1,300 per month. In order to meet the affordability threshold for 2024, when your plan year begins in 2024, you would need to set the employee's monthly premium cost and make sure it doesn't exceed 8.39% of $1,300, which is $109.07 per month. Using last year's and the last sentence there, that would have been, the math would have come out to $118.56. So again, that's your ceiling. That's the most that you can charge an employee for the lowest cost plan. Self-only coverage is $109.07 per month. So if you only require that your employees contribute $100 per month, then you're safe to use, well, it depends on your lowest paid person, but you're safe to use even the federal poverty level safe harbor because again, that can exceed $101.91. It's based on 14,580. So my suggestion to you is to determine which safe harbor you're using, have used in the past, and make sure that your employee contributions are set at or below one of these, depending on which one you're going to use. Are you going to use federal poverty level, rate of pay, or W-2? And make sure that you really can rely on that safe harbor and can safely report that 2F, 2G, or 2H without being in fear of getting an employer mandate penalty that says your coverage isn't affordable. Okay, question came in. Why do you look at the lowest paid employee? Because I think you got it, but just bears repeating. So if you have a higher paid employee, then we're not in danger of going over, because if you set your rate based on the lowest paid employee, then anybody making more than that is not going to not be offered affordable coverage. Okay, so you use the lowest paid person. So here's some open enrollment reminders. A couple of these we've already talked about, but these commonly get missed. So I want to bring them to your attention, especially if you renew pretty soon here in January or perhaps in December. You'll want to make sure that you're notifying your COBRA participants, including their spouses or children, of their open enrollment rights. So you'll recall, or maybe this is news to you, but the COBRA participants can participate in COBRA by themselves. So for example, if there's a termination of employment, the employee loses coverage and is offered COBRA, but they have their child or their spouse on the plan, that spouse could actually elect COBRA by themselves and be their own qualified beneficiary. So we don't want to forget about them in the context of open enrollment, because they can enroll in the new plan. They can take dental or vision if they didn't have it before. They have full open enrollment rights to your group health plan coverage and dental and vision that an active employee would. So please do not forget about your COBRA qualified beneficiaries and sending them the enrollment guide or the COBRA version of your open enrollment guide so that they can make sure and make those elections. This especially can come up if you change carriers, if you change insurance carriers, and they are not carried over to the new insurance plan, or that carrier isn't aware of this COBRA participant. That can be a very, very embarrassing and difficult conversation to have. So please, please pay attention to your COBRA qualified beneficiaries when we're talking about open enrollment, changing carriers, changing plans, electing coverage they didn't have prior years. They have full open enrollment rights, just as an active employee does. Also, similar is to notify anybody who's out on leave, who's out on FMLA leave, that they also need to make their elections for the plan year. That one is less likely to go unnoticed, but it can happen because maybe you can't find them, you can't get in touch with them. You'll want to make every effort to make sure that these folks on leave or FMLA are allowed to make changes just as though they were actively working. Ensure that no one who is enrolled in a general purpose FSA, flexible spending account, or HRA also opens and contributes to an HSA. So I told you guys that I was going to talk a little bit more about HSAs and some of the hangups here. So if you sponsor a health FSA, and a lot of you do, or an HRA, then your employees cannot also open and contribute to an HSA. So this is very important, and it will cause them to be disqualified for those HSA dollars, and they will have to essentially reconstitute those funds as taxable income on their taxes. That also can be a hard conversation. So if you're, again, sponsoring a health FSA and you also have an option with an HSA, then you want to make sure that people don't enroll in both, and you set up some kind of stopgap to make sure that they can't enroll in both. This also comes up, this is less of your responsibility, but I do think it's good to maybe add in your plan materials or talk to your employees about it. But if they are enrolled in their spouses or their parents' FSA, they cannot open an HSA and contribute funds to it either. So let me give you an example. This one always kind of surprises people, but it's very true. My husband used to work for a company, and he was enrolled in the health FSA. They did not offer a high deductible health plan HSA combination. However, I worked for another corporation that did and contributed probably $1,500 to my HSA per year. We realized that I could not enroll in my HSA and have those employer funds contributed to my HSA, because even though we didn't mean to, I was able to get my medical claims reimbursed by his FSA because we're legally married, and legally married spouses and dependent children are able to have their claims reimbursed from the employee's FSA, even if that's not their intent. It's just the fact that they're eligible sort of automatically. So again, for legal spouses and dependent children are automatically allowed to receive reimbursement, tax-free reimbursements from the health FSA or even the HRA in some cases. So you want to be careful that employees are not enrolling into an HSA, making pre-tax contributions, when in fact they're enrolled in their spouse's FSA or their parents' FSA that makes them ineligible in the first place. That again can leave them very upset and cause a lot of disruption. Now you can have, and many employers have this as a way to get around this issue, you can set up what we call limited purpose or post-deductible, either FSA or HRA, that doesn't pay benefits until after the high deductible health plan's minimum deductible is met. And so this solves the problem. It makes it HSA eligible. Sometimes you'll even seen them call that HSA eligible FSA, that doesn't run afoul or cause the coverage to be disqualified. So yeah, if you have all of this, if you have an HSA and your employees maybe are able to enroll in their spouse's FSA, you'll kind of want to alert this to them. But especially if you have both types of coverages that you offer, you want to make sure that that individual maintains HSA eligibility. Next, you'll want to obtain your employees' pre-tax elections in writing, at least for medical insurance, and especially if you provide an FSA or dependent care FSA, you'll want to get their new elections each year. Those amounts change each year, and it's a much better option than just simply rolling them into the next year because of wage withholding laws. There's a lot of reasons, but we want to get those employee pre-tax elections in writing if you use online enrollment system, some kind of documentation there, or a paper form if you go the paper route with applications. Distribute all of your required open enrollment notices. Again, this is a notice packet that Hausman Group provides you with and can assist with. The summary of benefits and coverage, the SMM in some cases, Medicare Part D notices, CHIP notice, HIPAA special enrollment rights, WICRA, HIPAA and EEOC wellness program notices. So if you've ever done a checkup with us, we go over these notices pretty carefully, but overall Hausman Group will provide you or assist you with getting customized notices that include all of these requirements here. If you do require dependent proof for enrollment into any of your benefits, so some of you do ask them to provide a copy of a marriage license, a birth certificate, tax returns, some kind of utility statement, something like that to prove dependent status. You'll want to make sure that for all types of dependents that you require the same level of proof. So if you only ask for an attestation for legal spouses, but for, dependent children or domestic partners, you ask for, some other type of proof over and above just an attestation, you'll want to make sure that you're just instead either only asking for an attestation from everybody, or you're asking for that higher level of proof from every type of dependent class, I should say. So just some key takeaways as we finish up today. And if you have any other questions, please go ahead and type them into the chat and I'll make sure to answer them. But some key takeaways for you, just reviewing all of these various requirements, pay attention to the upcoming requirements under the transparency and CAA rules, namely the gag clause prohibition compliance attestation that is due to CMS no later than December 31st this year and every year thereafter. You will want to confirm with your TPA, your medical TPA, if you're self-insured, if they will be attesting on your behalf. Probably not, but at the very least, they can give you some sort of letter or statement that says that your contract contains no gag clauses, so you can confidently go in there and attest to that fact. So, question came in, can you tell us a little bit more about a gag clause, maybe an example? So there's a specific example that I will include that's in the regs. I'd rather you read that, but essentially it has the effect, it would say something like that, and it may be something that you would have to ask for in your service agreement, where their stance on this is, but it would be saying that they, the TPA or the network reserves the right to provide any of their cost data to the provider reimbursements, that they they sort of had control over that data and that you really don't. So I have some good examples which I'll show you from the regulations. I'll include it in the slides, but overall it's just this restriction of provider specific data or quality of care data that could be construed as a gag clause. So consider your new limits for high deductible health plans and HSA contributions, including the age 55 or older catch-up contributions. If you have folks that want to throw in that extra $1,000, they certainly can if they're over age 55. Distribute your Medicare Part D credible or non-creditable coverage notices to all plan participants prior to October 15th. You can do that by mail, or you can do it by email, just depending on if your employees are allowed to receive documents electronically under the safe harbor. For applicable large employers, you'll want to ensure that employee plan year 2024 contributions are in fact affordable using 8.39% of W-2 rate of pay or federal poverty level. Again, the time for planning for that is now, not when you do your ACA reporting. And we have many other resources for you to help you to meet your obligations. Again, Housing Group is always out front with these requirements and has many resources and will assist with heavy lifting with most of these different options, whether it's helping you figure out if your coverage is affordable, helping you figure out if your coverage is creditable, meeting with your TPAs and vendors and carriers to see where they stand on these particular CAA requirements. So we will assist, but we do want you to understand your fiduciary obligation to make sure that you're in compliance with your health plan obligations. We also have compliance checkups available, which many of you have done with us. So ask your account manager for more information about a compliance checkup. Newsletters and alerts. We are always sending out newsletters, trying to help with reminders about certain different obligations, many of them that I mentioned on today's call. So please make sure you read our newsletters, review them, because they do contain important information. If you're not getting our newsletters, reach out to your Housing Group team and make sure that you're on the list. We have been working diligently, again, to identify the levels of TPA and carrier assistance with all of these CAA rules. So don't feel like you're left having to figure this out. Again, we do want to talk about it so that you'll know about it, because you may take some action on your part. But we are in contact with TPAs and have been asking them for months, and we're starting to get responses. So contact your account manager for more assistance if you're feeling a little bit unsure about some of these provisions. Question came in. Can you explain again what the RxDC report is from the Q&A? Sure. So the RxDC report, let me go back to my first few slides. Really doesn't say too much on this slide. I have so many slide presentations that I have it more robust in another one. But the RxDC report is a healthcare spending and prescription drug report. It's a submission that needs to be uploaded to CMS's HIOS portal, HIOS portal, by June 1st each year. Again, there have already been 2 rounds that should have been submitted by your carrier, by you, or by your TPA. This should not be a new thing that you're hearing about. However, if it is, or you are a little bit unsure if it happened last year, you will want to reach out to your Housing Group representative and see where that stands. Now, I will say that the last 2 years were, there was some good faith effort relief, but overall, I think getting it done this year on time is going to be the place you want to focus your energy, because there's really not a way to submit a late submission anyways at this point. What it is, though, is a series of 8 different data reports or data pieces of data. I shouldn't even say pieces of data, but spreadsheets that contain required data fields that have to be uploaded to CMS. So there are 8 different spreadsheets. Most of them are for prescription drugs, but 2 of them contain some information for the medical plan spend. There's also something called a P2, which is the plan cover sheet. It's a plan list that is to be submitted for referencing whose information this belongs to. So the reason it is quite complicated is, for one, getting into the CMS portal is a challenge. It's a government website, and it requires, again, a soft credit check, requires 2 different registrants to be able to cross-reference each other, and uploading all of this data that needs to come from your service providers, from your pharmacy benefit manager, and from your TPA, your medical claims TPA. And sometimes if you carve out behavioral health, there could be yet another party's information that would need to be incorporated to that report. So it's a complicated report that needs to be submitted to the HIOS portal. And again, medical TPA or carrier can submit on your behalf, but it might be possible that they don't have all of the information, because maybe the pharmacy is holding this piece and the medical is holding this piece, and there needs to be coordination. So if this is something that is a little bit overwhelming to you, you're not alone, for sure. Almost millions of plans were so overwhelmed last year on how to comply with this requirement. But I think as time has gone on and then the second round came due, I think there was a little bit more of comfort level on who was going to do what. So if you are unsure, you will want to reach out again to your medical TPA to ask if they assist with this, and ultimately to Housing Group to understand what do we need to be doing for this upcoming submission due June 1st, 2024. So hopefully that helps explain a little bit more. It is complicated, but we will have subsequent webinars on this again in early 2024. So here are the SHRM credits and HRCI credits for you. And if there's no more other questions, I'm just going to pass it back over to Cassie to close us out today.
Yes, thank you, Sarah. Yeah, and final call on questions. If you think of something after the webinar is over, you are welcome to reach out to your account manager or benefits account executive if you're a client with us. Otherwise, Sarah's contact information will be in the email as well if you want to email her a question directly as you think of it. And yes, we will be having more webinars on this stuff. I know we're going to blink and then it'll be early 2024, so it'll come up sooner than you think. And once again, this webinar is recorded and everyone will get a copy of the slides as well as a link to that recording. So thank you all so much for being here. And thank you, Sarah, for such an informative webinar. We hope everyone has a great rest of their afternoon.
Thanks, everyone.